All right, welcome everybody. Good evening, good morning, good afternoon, wherever you are in the world right now. Welcome to our bi-weekly GOWME lecture series. We'll get going in just a few seconds here as everyone else trickles in. All right, and I think we'll get started now. So welcome again, everyone, to GOWME for our weekly lecture tonight on dive medicine. Oops. All right, so if this is your first time joining us today, just to let you know what our mission here is all about. GOWME is a space where we aim to create an educational platform where interested students and healthcare professionals can explore and interact with wilderness and emergency medicine. We also aim to showcase the diverse spheres in which physicians and healthcare professionals can make an impact and inspire others to think about all the really cool ways that we can interact with careers in healthcare and medicine. And lastly, we hope to create an international community of wilderness medicine enthusiasts and experts who are all committed to promoting a diverse and culturally competent environment here in the wilderness medicine space. So if you haven't yet, we suggest that you strongly consider joining our mailing list with this QR code to the left. We're almost done with our lectures for this semester, but in the spring, you can look forward to a fellowship showcase and ongoing free stuff giveaways and certificate courses, among many other really interesting things. We also have a pretty active social media presence. I would say that one of their coolest features, in my opinion, is we record most of our lectures and we post them on our YouTube channel. So if you're looking for even more ways to get involved, check that out. And like I said, we have a gear giveaway going on right now. We have partnered with Pit Viper. They have lots of cool swag. So during this lecture, we will drop a link in the chat for you to add your name to a drawing so you can get added to that free swag giveaway by Pit Viper. And like I said, we're almost done with our fall lineup. We had a great series of talks so far. After tonight's lecture, you can look forward to one more talk in about 2 weeks on climate medicine. And that brings us to our speaker for tonight, Dr. David Lambert. Dr. David Lambert is an emergency medicine physician and the medical director of the Emergency Department Observation Unit for Hyperbaric Medicine and medical command physician for the Penn Star Flight Program at the University of Pennsylvania in Philadelphia. After graduating medical school, Dr. Lambert went on to complete a general surgery internship at the Naval Medical Center in San Diego. After becoming a U.S. naval flight surgeon, Dr. Lambert served on the USS George Washington in the Mediterranean and Persian Gulf Operation Southern Watch from 1999 to 2001. After that, he completed 2 tours in Operation Iraqi Freedom. In addition to being trained as a surgeon, he went on to complete an emergency medicine residency and hyperbaric and undersea medicine fellowship. He is a certified PADI advanced open water diver who has gone on several dive expeditions, including a bunch of names I will hopefully not butcher too much, the Kizi Burun's shipwreck in the Aegean Sea, Turkey, and the Godavaya shipwreck in the Indian Ocean near Sri Lanka. So that's our speaker today. I will stop sharing my screen and invite Dr. Lambert to take it away. Oh, and everyone, we suggest you strongly consider letting us see your great faces if you're feeling brave and you want to turn your video on. And if you have any questions, feel free to drop them in the chat. We will have time for Q&A at the end. That's all I got. That's all you did, Dr. Lambert.
Awesome. All right. Good evening, everyone. For those of you who are in the evening times, my name is Dave, and appreciate the introduction. I apologize for the noise. My 2-year-old just got home, so if it gets too loud, just let me know, and I'll try to shoo him away. Are you guys seeing my screen okay? Are you seeing it zoomed in, just the screen, nothing else, like presentation? Okay. All right. So just cover my background. So yeah, I was in the Navy. I was a flight surgeon. I then, after 9/11, went to the Marine Corps side and was in Iraq, for those of you who are former military. You can see the list of all the things I did. I then got out of the military, came back to the East Coast, did residency at Cooper, emergency medicine, and then went to Penn for fellowship. And I've been at Penn ever since then. All right, let me get this in the presentation mode. There we go. All right. These are all the, just for fun sakes, because I know a lot of the medical students are in here. Those of you who may be considering the military or are already in the military, these are all the different aircraft that I either flew in or were involved with, which has made a really fun career looking back on it. Just had a blast doing stuff like that. So anyone who's interested in the military career, I highly recommend it. Okay, I'm not gonna have to hit this button. So I traded the aerospace for the undersea, and it's been a lot of fun. Not quite as adventurous when I was young and single and flying around the world, but still a lot of fun. And so that's what I'm going to talk to you tonight is about some of the stuff I do as a hyperbaric, undersea and hyperbaric medicine physician at Penn. I still do get my my fix with flying because I work for Penn Star, so I am flying in the helicopter with the crew once in a while. So kind of a fun little career path that I've had. And I was talking to Katrina earlier before the talk that it's just a lot of fun. Emergency medicine provides a lot of opportunities for those of us with an adventurous sense of adventure to be able to do things like that. Objectives of this talk. I am not going to do all this, I think, for the sake of time, and also, because, I just don't think it's worth going into all of this, but this is the stuff that I can talk about. Okay. And I obviously can't do the gear demonstration, but normally when I do this talk, I do it at Jefferson where they have a wilderness medicine conference, the Eastern Wilderness Medicine Conference. And I bring in a rebreather, and some open circuit scuba stuff so everyone can see it and try it on and see how heavy it is or what it feels like and things like that. And it gives you some good understanding of what it's like to scuba dive. So in terms of undersea medicine or underwater activities, it goes back really far. I mean, thousands and thousands of years ago, man started to try to figure out what's this thing called the water and the ocean, and how do we get these things called fish and other precious materials down below. So a very long time ago, sponge fishermen have been diving for thousands of years. Alexander the Great was in a diving bell. But really, when we come into the 20th century, it's Jacques Cousteau and Dr. Lambertson from Penn, who pretty much started our clinic where we are, and the chamber is the same chamber he worked on. He came up with the term scuba, and he was very much on the scientific ends of the hyperbaric undersea medicine world, where Jacques Cousteau was more on he designed the aqualung and the modern open circuit scuba. These two were kind of like the Bill Gates and Steve Jobs of the world in undersea medicine. So you had Jacques Cousteau out there getting the word out there to the general public, and Dr. Lambertson working in the background, just doing the academic sides. He's considered one of the grandfathers of the Navy SEALs because without his expertise in the scuba diving world, they would not have been able to develop the rebreather apparatus, which they use for diving underwater undetected. All right, so just to really kind of level set and just make sure you understand, there's more than one type of scuba diving. And so just to make sure everyone understands that when it comes to undersea medicine or scuba diving, I'll use the terms interchangeably. There is recreational scuba, which is what everyone thinks of when they think of scuba diving. But there's other things beyond recreational. There's scientific and educational diving, which I do, as well as recreational. Then there's going to be public safety or rescue diving. So that's going to be your police, EMS, government, stuff like that. Then there's going to be commercial scuba diving, which is a lot of oil platforms, working on bridges and tunnels, working on barges and ships, building windmills off the coast, things like that. So those are commercial divers. I mean, pretty much underwater construction. And then there's going to be military, which is going to be obviously can be anything and everything. Is my kid too loud? Is it loud?
I think it's okay, Dr. Lambert. We can hear them, but
All right.
they sound really interested in this talk too.
Yeah, I don't know about that. All right. So again, those are the basic categories of types of diving. Now we talk about modes of diving. Okay, so we have the scuba, which is the self-contained underwater breathing apparatus. That's going to be pretty much the recreational scientific. Let me close the door. Sorry, he is loud. All right, maybe that'll help. The problem is, any of you have a 2-year-old, I close the door, that's going to draw attention. He's going to try to come in. Okay, so we have the self-contained underwater breathing apparatus. And that's going to be pretty much what most recreational divers do. That's the most common thing you see. Scientific, educational, public safety divers will do open circuit scuba. Surface supplied, that's going to be more the commercial and the military, sometimes public safety. You can see in the bottom right-hand corner, that's going to be a surface supplied. So although they do have tanks, they have a nozzle, a tube that connects to their hard helmet, their hard hat helmet, and they can breathe whatever breathing gas you're providing them from the surface. So, and there's communications with that. That's going to be primarily, most of what you're going to see is going to be commercial divers. Then there's going to be saturation diver. This is a very special type of diver, very, very specialized. These are people that are down underwater at depth for so long that their body tissues become saturated with the breathing gas molecules that they're breathing. So, and they can't just come back up to the surface safely. So they sometimes spend days and days at this pressure depth. Okay, so that's a saturation diver. That's a whole subject, like days and hours of lecturing in itself. And then there's the dry environment diving, which people don't think about, but that's where I live and that's what I do every day. That's the hyperbaric environment. So we have techs, EMT paramedics and techs that work in our chamber. They are essentially diving physiologically every day. When they go in that chamber, when I go in the chamber, I was in the chamber on Sunday with a patient. I was essentially physiologically scuba diving. Okay. Just wasn't with scuba, but I was diving. So it's the same physiologic principles that I'm going to go over. Then there's tunnel boring. So any place, and there's a lot of tunnel boring going on around the world right now. Anytime they're underground and they're boring tunnels and then underneath the earth and the earth gets soft, they have to create a pressure gradient in front of the boring machine so that the earth doesn't collapse. And so they go into a pressure like situation where they hold the walls up while they're laying down the cement. The workers down there are working in a pressure environment. And then caisson disease, caisson workers. So people, when they're building bridges, they're going to be in these caissons, which are a pressurized chamber at the bottom of a river floor, for example. All right. So that's some basic modes. Okay. Recreational diving is pretty much diving that's conducted for fun and sport. It's pleasure diving. Typically speaking, clear water, you go down there, you observe stuff, you look around, you have fun. Then you start getting a little bit, oh, this looks fun. Let's go inside that hole. Oh, look at that old shipwreck. Let's go inside that shipwreck. It spans the spectrum of super chill. I go to the Caribbean, I go to Hawaii, I'm in 20 feet of water, to, hey, let's go to 130 feet and go inside a cave and be on a rebreather and almost die. So recreational diving has a tremendous spectrum of risks. Okay. And we'll talk about that in a second. Most recreational diver, like I said before, is going to be open circuit. It's the most popular. It's what everyone associates when they think of a scuba diver, that person in the middle. But if you look on the right or left on the bottom, that on the left, that is a closed circuit rebreather apparatus. In other words, when the diver is connected to that apparatus on their back and they are breathing gases, they are completely closed circuited. There are no bubbles coming out. Their inhalation, exhalation is completely contained inside of a single loop that filters out the carbon dioxide and then filters back them with a gas diluent mixture. And then they breathe back in the gas again. And then again, breathe out the carbon dioxide. Very simple, straightforward. It's just a closed loop and you're filtering out the carbon dioxide. Used to be a lot more risky than it is today. They've come a long way in the last 20 years to the point where they're very, very safe with the proper training. Recreational diving, just to kind of quickly understand, it's the best thing about it is the lifetime certification. Once you get certified, I was certified in college when I was a freshman in college. And it's great. There's not much oversight. Once you have a certification, you're good to go. You can go out there and dive. You can travel around the world and say, yeah, I'm a certified diver. It lasts a lifetime. The cons are it lasts a lifetime. Well, over the course of my life, my physiology has changed. I've had events in my life. I'm older. Things change, right? Your medical risks change. My comorbidities change. I might be on medications now. Things happen. So it's really, really dangerous. It's probably one of the most risky things that we do is we see people who've been diving for 20 years and they have all kinds of medical problems, specifically like asthma, diabetes, cardiovascular disease, and they need to be screened properly because scuba diving, like it or not, is a physical activity. So whenever we think of scuba diving, remember there are some basic minimums that have to be considered when you think about like their metabolic equivalents when they're doing like a stress test and stuff like that, because When you dive, you never dive alone unless you're a very experienced rescue diver, or certain divers dive alone. But most diving is always performed with another person. So whenever I evaluate a scuba diver, a recreational scuba diver, that is, or rescue diver, I'm always taking into consideration, okay, if I think this person's marginal in terms of diving because they have risk factors that put them at risk while they're underwater, I have to consider the fact that they could be diving with somebody else. So whenever you're talking to a friend, family member, or a patient about whether you can or cannot dive, if you can pass the physical exam they throw in front of you, hey, I'm going to the Caribbean. Can you sign this form for me, doc? You have to take into consideration the fact that if you give them the authority to dive, you're also putting somebody else at risk. So I can't underestimate that. And I cannot like underline, bold print, whatever, that enough. You are always, there's always somebody who you don't see right there. There's another human being. And there's a lot of, unfortunately, dead divers and injured people because their buddy had an emergency. They had to go save that person, and they both get injured, or vice versa. Somebody dies trying to save a person. So always keep that in consideration. The other downside of recreational diving is there is no commission, there's no legal authority, there's no FAA to use an equivalency like for pilots. Yet there are some risks out there. Oddly enough, there's a lot of people diving and very few injuries. So we're I guess as we are self-selecting, those of us who are going into diving, people are realizing very quickly, any of those of you who are divers out there, you're pretty much, there's certain things you remember in life. Like it used to be, say, people can remember like where they were on 9/11. I think some of you might be to the point where you don't remember 9/11, but there's certain things you always remember in your life, right? What you were doing when. I'll never forget the first time I breathed underwater, right? You just will never forget it. And I think that's a very sobering moment in life. So we potentially self-select, which is why divers generally stay safe. However, you might have somebody who hasn't dove in 20 years and they come to you and like, hey, I want to get a dive physical. And they said, I need to see you. And they're 55, diabetic, hypertensive, overweight, and have mild asthma. Like there's going to require some thinking before you just say, yeah, go ahead. Here you go. Sign the paper. Divers tend to be seasonal, so they only dive in the warm months in the warm water. So they really don't they lack proficiency in dangerous areas. So you always want to ask, okay, where are you going? Are you going to be out of the country? Are you going to be on a live aboard boat? Are you going to be, in warm waters? This cold water? Oh yeah, I was going to go up to Alaska for the first time. I literally had a diver who's never dove in cold water, was going up to Alaska and diving through the ice. So it takes a lot of thinking before I approve them to go diving. And then there's equipment maintenance. If I'm only diving once a year and my equipment's sitting in, I put it away wet maybe, and it's sitting in my garage or in my basement, there's a lot of chance that equipment can malfunction. So a lot of things to think about when you think about recreational diving and when somebody comes to you because they want to go diving again. So that's kind of recreational diving. So you can see it's family, it's fun, it's cool. You see the fishies, you go on vacation. 98% of the time it's safe and there's not a problem, but and it spans a lot of risks. So you want to ask the diver, what are you going to be doing? Are you going to be doing a shipwreck? Are you diving on nitrox? That's going to be oxygen enriched air. So they're going to be, basically having them, so they call it nitrox. So they're taking the nitrogen out of the air mix so that you can have more oxygen, less nitrogen. You can dive longer, but not as deep. So things like that. So you're always gauging a patient's abilities, their comorbidities. Also, though, what are they doing when they're going to be diving? Where are they going? What's the condition like? What's their experience? How long they've been diving? There's a lot of things to think about when you think about diving. So that's my general recreational diver spiel. You can see recreational divers can do a lot of things. They can be in kelp beds, they can be in caves, they can be in wrecks. So you really need to kind of talk to your diver and know what they're doing. You can see this person here is with another person. So there's always a buddy diver. Don't forget that part. All right. Scientific education. That's kind of the stuff I do out of Texas A&M with the Institute for Nautical Archaeology. This is kind of cool stuff that we do where we go on research trips and we're doing undersea archaeology. It's a lot of fun. Some of you may have done some expeditions. They're always looking for volunteer divers who are interested in science and archaeological stuff. But basically, it's the standards to become a scientific diver are actually lower than recreational diver, but it's because it's not really, scientific diving is not like moving heavy objects. There's no construction, demolition. We're not cutting, welding. We're not doing any of that stuff. We're doing a lot of just looking around, counting fishies and things like that. I mean, we do some heavy lifting, but we have professionals come in and help us when we do that stuff. The boat here in the middle is a live aboard boat that's now out of commission, has a hyperbaric chamber inside of it. It's a World War II boat that was converted into a live aboard dive research vessel in Turkey. It's in Badrum, Turkey. But you can see on the corners there, those are some examples of what scientific divers do. This is what one of my dive expeditions we were doing. We found some Doric columns, marble columns that were sank in about 2010 BC, and at the bottom of the Aegean Sea at 160 feet, 150 to 160 feet. And we were raising them, and you can see we had to flip them first, and then we were raising them. So we put these straps around them, filled the airbags with air, and as the airbags got bigger, by Boyle's law, they of course expanded and went to the surface, and they would flip these 3-ton Doric column sections over, and then eventually we were able to raise them to the surface, and they're now in a museum. So that's scientific diving. Then there's the public safety diving. These are going to be your EMS. These are going to be, this is that ship that capsized off the coast of Italy about 15 years ago. They're going to be people who are going to be out there doing very dangerous work, often in toxic environments, hot water, cold water, contaminated water, pulling out dead bodies, things like that. So really difficult stuff, very specialized. They come a lot for physicals, but when they come, they're going to have very specific forms, and it's going to be pretty straightforward about what their requirements are. Commercial diving, something I do a lot of at Penn. We have a lot of contracts with commercial diving unions and outfits here on the East Coast because of the windmills that we're putting up. And there's a lot of operations, as you can imagine, with the ports of Baltimore, DC, not DC, but Baltimore, Philadelphia, New York. So there's a lot of commercial diving operations going on around here. So these are going to be basically, I just say they're construction workers underwater. And these people have very specific requirements. There is an overarching commission and agency that looks at these companies and looks at the diving certification and qualifications. There are both international and American standards, and depending on the diver and who they work for, we have to follow different standards. So that's kind of and then there's military diving. Now I'm not in the military anymore, and I wasn't a dive medical officer, but you would imagine those of you who are in the military, they have very specific requirements for the divers too. But generally speaking, you're talking about young, very fit young men and women who are going to be doing these types of jobs. So the physical fitness isn't going to be as much of a problem as it's going to be just the technological aspects of what they're doing. Okay, so that's kind of the types of diving, the type of patients you might see when you're doing dive physicals and things you might do. Okay, now there's open circuit. So open circuit is going to be pretty much, your general majority of what your divers are going to be doing are going to be open circuit. That's what I do. That's what 93%, 94% of all scuba diving is around the world. You can see this. They're going to have a wetsuit generally, a buoyancy control device. They're going to have fins. They're going to have booties. They're going to have a dive computer. They're going to have a gauge, pressure gauge. They're going to have a 2-stage regulators, right? And a rescue regulator. They're going to have a snorkel and a mask. That's your general setup. What you don't see here is a tank filled with your breathing gas. I don't say air because not all tanks are filled with regular air that we're breathing right now. So we can change the gas mixture to fit our dive profile. And we'll get into that in a second. Oops, sorry. Okay, so and then there's the closed circuit. We'll just, we're not going to get into semi-closed, but basically closed circuit, that's going to be the rebreather apparatus. These things are awesome. I showed you a picture one earlier. These things are amazing. The only limitation right now is basically the human limitation of your endurance. They can go almost for hours upon hours at depth. And pretty much the diver's going to wear out before the machine does. They are really, really efficient. They allow you to go almost anywhere. You can go a lot deeper because of the way the gas mixtures work. Again, it's a little longer conversation, but really amazing stuff. The danger in the rebreathers, these are the things that don't put out bubbles, or if they do, they're very, very small bubbles. There's tremendous potential for sudden hypoxia, sudden hyperoxia, or hypercarbia, or what's called a caustic cocktail. In other words, when something fails, it fails dramatically and usually pretty quickly, and it's usually doesn't end well. Again, like I said, these apparati are getting much, much more safe and are becoming more technologically advanced. They're very computer driven and experientially driven. So the people who use them more, it's kind of a use it or lose it type of thing. You don't just pick these up and do it once a year. If you get into rebreather, closed circuit scuba diving, you're probably going to be diving almost year round because it lends itself towards increased safety. But again, like I said, there's reports of people diving very, very deep on these, so 500 feet, and not having to do any of the special decompression tables because you can change, the computers can sense how deep you are and will change the gas mixture that you're breathing. So pretty cool stuff. Again, really, really cool. And what's amazing is you can now get certified to breathe a rebreather through the PADI initial certification. So there are people out there who are now learning to dive rebreathers without going through the standard open circuit. So again, from a doctor's perspective, from what I do for a living, the first thing I want to do is what type of diving do you do, or what type of diving do you want to do? And I have like a 16-year-old kid whose mom sends him to our clinic for a physical, and they're going to, they're going to Bora Bora or something. I want to know exactly what they're doing and where they're going to get their training and what they're planning on doing. So this is a more technological thing of what's going on with the rebreathers, but how the gas mixtures work and the gas diluents and how you can get a caustic cocktail. Not going to go into all of it right now, but that's kind of what they look like when you break them up. In the middle here, you can see what's very computer laden. You can see this is basically your filtration device, which you're going to filter out carbon dioxide. You pour these little pebbles in there, which actually will be absorbents, and they will absorb carbon dioxide. And it's an exothermic reaction, so it gets warm. So there's a lot of things happening here at once. I am not a rebreather. I do not breathe. I do not do a lot of this, so I cannot get into the technical specifics of it. So any of you who are probably know more about this than I do. But I know enough about it to know, like when I'm doing a physical on somebody or talking to somebody about it when we're examining them. Surface supply, I'm not going to really get into it because it's not really part of the audience here, but this is basically, these are your commercial divers, military divers. So again, it's the old traditional scuba dive person that you think of, Jules Verne at the bottom of the sea with the hard hat and the breathing tube. They can go very, very deep. And these can be saturated divers who are living at the bottom of the ocean or in sea labs, such as like, the Aquarius Sea Lab, things like that. And these are going to be your divers down in the Gulf of Mexico who are working on the seafloor, working on the oil platforms and stuff like that. All right, so that's an example of what some of those things look like. All right, and then there's the dry environment. I talked to you about the tunnel boring machines. You can see there's a picture on the right. It's not a real picture, but that's kind of what the machines look like. There's these giant machines that are digging through the earth, and they are on these tracks, and they're laying down the walls of the tunnels, and they require hyperbaric modes from time to time. So kind of cool. Kind of there we are. All right. So that's kind of like what the diving is. That's what divers do. That's what we do. That's what I do for a living. I think now it's a quick time just to pivot into what I am on call for. So I do dive physicals. We take care of patients. Those are the things that I take into consideration when I'm taking care of a diver. When somebody comes into me and they want to get a dive physical, I have to assess all the different permutations that I just talked about. Now, when I'm on call and somebody's diving, how do they get hurt? What happens to a diver when they're underwater, and how can divers get hurt? So there's this thing called dysbarism. Of course, that has to do with the physiology of diving. That has to do with the physics of diving. All right, that's pressure, time, depth, and the gas breathe. And we can talk about this. This whole part right here could be another whole lecture. So I don't want to go into this in too much detail, but I'll just go back and say divers can get hurt in many different ways, right? They can get hurt by just trauma in and out of the boat, falls, head injuries, cuts, lacerations, things like that. But there's also they can get marine envenomation, they can get stung by animals, they can get bitten by animals. There's other non-physiologic diving things that they can happen to them. They can not be wearing the proper gear and they can be exposed, right? So they can get cold, hypothermic, and then make mistakes, and they can drown, they can aspirate, they can have a heart attack. And there's a lot of things that divers can do. So I think a lot of that stuff kind of makes sense to the audience. I don't want to go into those details, but I think from the standpoint of what I do for a specialty and what a hyperbaric physician does and how we think about diving, most of what I think about is going to be dysbarism or decompression illness. Okay. So again, when you're diving, you go underwater. When you go below the surface of the water, you're basically compressing. There's going to be an increase in the pressure around your body. Okay. And because of that, things can happen. One, gases get concentrated. The breathing gas the molecules in the breathing gas get concentrated, but also there's this pressure change as I go down. Anybody who's been on an airplane, an elevator, or been in the water, if you dive down deep, you're going to feel pressure in your ears or your sinuses. For scuba divers, there's other things to think about because you might be in a dry suit, you have your goggles to think about, you have to think about equalization and that nature. So that's going to be pressure related stuff. So that's barotrauma. But then there's the whole idea of being down underwater and this pressure for a long time, and you can absorb the gases that you're breathing, right? And those gases can then dissolve into the body. And then when you come up to the surface, they want to come out of solution. They want to come out of your tissues, and they can coalesce and form bubbles, and those bubbles can become a big problem. Okay. Or if you come up too fast, again, you can have a pressure related problem. You can develop an air gas embolism. So all kind of cool stuff. That's just a graph that shows you how rapidly pressure underwater changes compared to when you go to like when you go to outer space. So you can see when you go at sea level, or 1 atmosphere at sea level, right there in the middle of the green bar. But by 2 atmospheres, by 33 feet, you've already doubled your atmosphere. But you can go to 34,000 feet and you haven't even gone down to zero yet, right? So it just shows you how rapidly the pressure goes up when you get underwater. That's all that's for. These are the 3 laws that really guide. There are some other ones, but these are the 3 principal laws of undersea medicine once a diver's in the water that we worry about, right? So Boyle's law, Dalton's law, Henry's law. And I'm going to go into detail a little bit more about those in a second. So Boyle's law. Boyle's law is the big one, right? Boyle's law is basically as we go deeper into the water column, anything that's a gas bubble is going to get smaller just by pure physics. The pressure around your body, the pressure around that air pocket is going to get smaller. So on the right-hand side, you can see a diver takes a big breath and gets in the water and dives down, free dives down all the way down to 297 feet, 10 atmospheres, right? So the atmospheric pressure times 10, you can see their lungs are 10% of what they were at the surface. As long as they don't take another breath of air from anybody else, that their lungs are going to go back to the same volume, right? But now imagine if you're a scuba diver and you're down at, let's just say 66 feet, 3 atmospheres. So your lungs are 1/3 the size they were at the surface, but you're scuba diving. So your lungs are expanding because you're now expanding your lungs, right? So you took a breath. So if you're at 66 feet and you have something goes wrong and you panic, or something scares you and you start shooting to the surface and you don't breathe out that air, your lungs are going to go to 3 times the volume of what you just had in there, and you're going to basically rupture and develop pneumothorax, right? So that's Boyle's law. That's the balloon getting bigger and smaller. Same principle apply to your goggles. If you're wearing your goggles and you go underwater and you don't equilibrate the air in your goggles between the mask, and your eyeballs, what's going to happen? Your eyeballs are going to try to come out of your head towards the mask, because the mask can't change. That's a piece of glass or plastic, right? So what's happening is as you go deeper, the mask is going to get closer and closer to your face. Your eyeballs are going to try to get closer and closer to the mask because that airspace is going to get compressed. And if you don't put air into your mask, you're going to end up with giant retinal hemorrhages. I have a picture of that in a second. Same thing would apply for your ears. If you're not equalizing your middle ears, you're going to rupture your eardrum, or you're going to rupture your round window. Okay. So barotrauma of descent. As you go down the water column, pressure increases by Boyle's law. And anywhere there's an air pocket, you can get trauma, right? You can get pain. So as the air pocket gets smaller and smaller, you have to equalize. That's why you can never dive when you have a cold. You should never dive if you're having asthma. You should never dive if you don't know what you're doing. You know how to equalize. Okay. If you have a dry suit on, you can get little pockets of air in the dry suit, or even in some of the wetsuits, and it'll pinch your skin and you'll get a suit squeeze. If you have a toothache or an abscess, you can get an air pocket that can get squeezed when you're going down. Equally, when you're down, once you're down and you've equilibrated and you're having fun and you go up, but say you had a mild cold when you started diving, but your cold got worse underwater, or you had something else bad happening and you develop some more air, and then you don't, you come up to the surface and you can't clear your ears or your sinuses because you have congestion. Well, that air pocket in your sinuses are going to want to get bigger. And if it can't get bigger, what's going to happen? You're going to bleed. You're going to get what we call a reverse squeeze. Those are fine. I mean, you can live with those. That's a little bit of pain. but they're not in the lungs, right? So if you come up too quickly, or you have like asthma or some sort of restrictive lung disease, and your lungs can't clear, and you have a little bleb, and as you get closer and closer to the surface, that bleb's going to expand, it's going to expand, it's going to rupture, and you're going to get a pneumothorax, right? And pneumothorax can lead to problems. Obviously, pneumothorax is the problem, but also can introduce air into the circulation, to the wrong side of the circulation. You can develop air gas embolism. So those are some of the things we worry about. This other thing called alternobaric vertigo, that is when you have unequalized equalization. So unilateral equalization. So you don't equalize on the same side. So I'm going down or up. Happens more often when you're coming up, and I'm trying to come up, and my middle ears are expanding. I want to equalize, but my right side is congested for some reason. I can't get the air out of my middle ear, and it's getting bigger and bigger and bigger. It can't ventilate. My left side is doing fine. I'm going to get a mismatch in feelings in my brain, and I'm going to get vertigo. Right, I can develop vertigo because my brain's sensing two different things, especially if my round window ruptures or something like that. And you can then, of course, vertigo underwater is not good when your life depends on you being able to keep that mask in your mouth. All right, so that's kind of some of the stuff we deal with. So there's barotrauma. I talked about pneumothorax. These are some of the concerns we worry about. This is stuff that we think about when somebody has an emergency underwater. You can obviously, everyone knows what a pneumothorax looks like on a chest X-ray. You can get a small pneumothorax and not get like a tension pneumothorax like you're seeing there on the top. You can just get subcutaneous emphysema, shoots up the neck. You feel the crepitus in the neck. You'll all, at some point in your careers, you're all going to experience, you're going to feel crepitus. If you ever are in the emergency room or in the hospital and someone says, oh, there's a patient with crepitus, I would not run, but please ask if you can examine that patient, because once you touch crepitus, you'll never forget crepitus. And so you will see people with crepitus in the neck or the mediastinum from a ruptured bleb or a pneumothorax that's mild, doesn't cause the tension pneumothorax. Okay, and then you can develop air gas embolism, because of course, if you develop a ruptured alveoli from barotrauma, you now can send air directly into the pulmonary vein, which is going to go in the left side of the circulation, straight out the heart, either into a coronary and can cause an MI, or it can go to the brain and cause a stroke-like symptoms or an air gas embolism, or to the spinal cord or things like that. Most commonly, the thing we dread the most is going to be air from a ruptured bleb going into the left atrium, left ventricle. I mean, to the left atrium, left ventricle, and then boom, straight to the brain and causing a cerebral air gas embolism. This is typically going to be a patient who's at the diver gets to the surface, because the greatest change in pressure is going to happen closest to the surface. If you remember, if I go back to this picture here, the greatest change in volume happens from 0 to 10 meters. So from 1 to 2 meters, you can see you get a volume change of 50%, right? So it's usually right when you get to the surface, when you get that double the expansion of volume in the alveoli, then it ruptures. You then get air on the left circulation. It goes directly to the brain. That's why it's a famous board question for anyone who goes to emergency medicine. If a patient comes to the surface and has altered mental status, or passes out, or syncopizes, or is basically obtunded within 10 minutes of surfacing, that's an air gas embolism until proven otherwise, right? Decompression sickness, on the other hand, starts a little bit later. So let's talk about decompression sickness. So decompression sickness really has to do with a couple other laws. So there's Dalton's law of partial pressures, and this has to do with, we can change the mixture of the gases in the air we're breathing. So Dalton's law, we're basically breathing, our normal gas mixture, like room air, what we're all breathing right now. For all intents and purposes, it's 79% nitrogen, 21% oxygen. There's a couple other things in there. They don't really matter per se. All right. So we can now change the mix of the partial pressure. So we can change the different gases that we're breathing in the tank. And because doing so, we can then change what happens to the gases that we're absorbing into our system. Equally, though, if we change the air mixture and we can alter it, we can also reduce the symptoms of something that happens when you're breathing regular room air. Let's just say, for example, room air, the air that we're breathing, we put in a tank, we go down to pressure and we start breathing that gas. Well, at 3 atmospheres, so I go down to 66 feet, I'm going to increase my percentage, even though it's room air, it's the same percentage, 79 and 21%, right? I'm going to increase the percentage of oxygen and nitrogen per breath. So the concentrations are going to be up threefold. and that's dangerous, right? So even though by ratio I'm breathing the same gas mixture, I'm still increasing the amount of molecules that I'm breathing into my body, and that can cause effects, right? So there's a thing called nitrogen narcosis. So this is basically nitrogen. Anyone who's been to the dentist and had nitrous, or has been in anesthesia, and they tell you about the old school nitrous, you increase nitrogen in the body, the brain eventually will, it's like an anesthetic, right? So scuba divers can get a thing called nitrogen narcosis because they go too deep. There's too much nitrogen in the breathing gas and it goes directly to their brain, and they can become a little bit loopy. They can become goofy. They can feel like they're drunk, right? Similarly, oxygen toxicity. If you're going too deep in the water column, pressure goes up, the oxygen concentration increases because of pressure and the depth. So every breath you get more oxygen in your body, even though it's the same ratios, and that oxygen can cause oxygen toxicity. How does that manifest? Usually by a seizure. You have a seizure underwater, again, you're going to spit that regulator out of your mouth, you're going to aspirate, you're going to drown. So when we look at why people die while diving, the pathologists really have to do a lot of investigating. They have to look at all the gear. If there's ever a death, we take all the gear. We have to look at everything and try to figure out what was the cause of the drowning, because it's not always as obvious as you think. There's this thing called rapture of the deep. Essentially, if you're breathing regular room air and you're normal 21% oxygen air in your gas mix, and you go down to 60 meters, you will perform and act and feel similarly if you were to have 4 martinis. Now, obviously, that changes person to person depending on how much you drink, but general rule, it's called 1 martini per 50 feet of seawater, FSW. All right, all right. This is the last part, and then we're going to wrap up. The last thing you need to think about is Henry's law. Henry's law is pretty much really, that's the money right there, okay? Henry's law is basically the amount of gas dissolved in a liquid and tissues is directly proportional to the partial pressure of that gas. So as we go deeper, the gas that we're breathing, because Dalton's law is the ratios, that gas, whatever the ratios that we give the diver, whatever we give them, as they go deeper and deeper, they're going to absorb more and more of that tissue. So we have the concern for narcosis and oxygen toxicity. But now, if I go down to 100 feet and I stay down there for a really, really long time, I'm going to absorb a lot of nitrogen. The oxygen I'm going to use, right? So oxygen gets utilized pretty quickly. I'm going to breathe some of that off. But the nitrogen, it's an inert gas. I'm going to absorb a lot of that nitrogen, and that nitrogen is going to get distributed to the tissues. And there's a whole other there's a whole other form of literature to talk about how it's absorbed, but different tissues absorb at different rates. But at the end of the day, if I go down for too long, we have dive tables that tell me what I can do. They tell me my limitations. If I go down for too long and I exceed the dive tables, which have been built over time, I'm going to absorb too much nitrogen. If I absorb too much nitrogen, I cannot come up to the surface at the same rate that I went down. In fact, I have to come up at a very controlled manner, but I may not have enough air to breathe to come up at that rate. So you have to adhere to the dive table. So it's a mantra we say in diving all the time. Plan your dive your plan. You don't just jump in the water and go willy-nilly, because if you exceed the dive tables and you're down for too long, you absorb too much nitrogen. When you come to the surface, that nitrogen has to come out. Just like if you take a soda, or whatever, a seltzer, and it's closed, you buy it from the store and you shake it, it's still going to look there. You might see a couple bubbles, but then if you open it up, those bubbles want to come out, right? They're going to come from somewhere. You don't see them when the cap's on, but you open the cap, they're going to come out of nowhere, right? Because the carbon dioxide is inside that soda or inside that seltzer. That carbon dioxide needs to come out because you release the pressure. So that's what coming to the surface is. When you come to the surface, you're essentially taking the cap off of a soda bottle, and your blood and your body is basically the fluid in that soda bottle, and all of a sudden bubbles are going to come out of nowhere. Now, we do know that people get bubbles, right? Bubbles are normal. We all can tolerate bubbles. Our lungs are really good filters. But if you get too many bubbles too fast and the bubbles coalesce and get in the wrong place, they get stuck and they can cause what's called the bends. If you get bubbles that are too big and they can cross for different reasons, cross from the right side of the circulation to the left side of the circulation, bubbles in the arterial side of the body can be air gas emboli. Okay. So there's some other things that I don't want to get into here, but there are other things going on besides bubbles. But generally speaking, from at the basics standpoint, bubbles are the main problem. Nitrogen bubbles are the main problem in the average recreational scuba diver. There's other things going on like microparticles that we're looking at, but that's a more longer conversation. I have some slides in there I can talk about. But what happens? Bubbles are formed from these supersaturated gases. They get into the organ tissues. They can cause organ injury. If you have a PFO, you can shunt some of these tissues. Some of this nitrogen gas can be shunted. At the end of the day, bubbles can lead to organ injury. Okay, so if you have too many bubbles and your lungs can't filter them, you're going to lead to organ injury. Okay, so that's going to be decompression sickness. Problem with bubbles is they release an inflammatory cascade, because if you have a bubble stuck in the circulatory system or in a joint space or in a nerve, there's going to be inflammation. There's going to be the complement system is going to get activated. Coagulation system is going to get activated. You can get them in different parts of the body, create different symptoms, and that's the stuff we talk about. Okay, so all right, that's in a nutshell what we're talking about with diving. So we have the different types of divers. We have to assess who they are, what they're going to do, what they're going to be diving, and then once they are diving, my biggest worry is don't get decompressed. Don't drown, don't fall off the boat, don't hit your head, things like that. But then it's like, don't dive when you have a cold. If you have asthma, don't dive, because these are risks that can put you at risk for having decompression sickness. There's a lot of other risks out there for getting decompression sickness, but you can see if you understand the main gas laws, Boyle's law, Dalton's law, and Henry's law, you will get yourself through 99% of a diver evaluation in an emergency department. I'm just going to pop out of here for a second. Let me just get out of here and don't be overwhelmed by all the slides. I'm going to just wrap up because I'm going to skip all this stuff. In terms of hyperbarics, okay, what do we do? So if somebody does have a dive injury, we treat them in a hyperbaric chamber, right? So what do? We put them back at 60 feet, and we do what's called a U.S. Navy treatment table 6. So we are going to take any bubbles that they have. We're going to recompress those bubbles. They're going to breathe on the green strip is going to be oxygen. They're going to breathe 100% pure oxygen. They're now creating a window where there's no more nitrogen. The nitrogen that they absorbed earlier has nowhere to go. It has to leave the body. They're going to keep breathing. We crushed any bubbles that grew, so we shrink any bubbles. We're going to now allow the body to off-gas all the nitrogen that was there from the dive. If we have to do extensions, we will, based on their symptoms and their neurochecks, because we do neurochecks at depth, right? But then the whole idea and the whole premise of a table 6 is we're giving the body a chance to recover. And there's, oh, by the way, there's some benefits from the oxygen molecule, the hyperbaric oxygen molecule, creating anti-inflammatory properties. So that cascade of things that have started, we can kind of mitigate that and turn that around. Okay. Just for time's sake, I don't want to go through it, but there's a lot of ways to assess these patients in the ED. And I'm going to end with this. So in the ED, I mean, in the United States, there's about 3,000 scuba dives that happen a year, but there's only about 1,400 ED injuries reported annually. So that's only about 1 in 20,000 dives. A lot of patients that might get injured might self-treat, yes. The diving fatalities are very, very low. So while I might talk about all the ways to die, you're talking in only 2 deaths per 1 million dives. So that's not too bad, right? There's obviously a lot of comorbidities that contribute to a lot of the fatalities, because I did mention that we could drown. So being over the age of 40 and being morbidly obese are risk factors. And basically, I think it's common sense. If you're not fit and you're not doing it a lot, you put yourself at risk, because it is a fun hobby. There's a lot to think about when you're diving, a lot of moving parts and stuff, but it's a lot of fun. It's visually stunning. You're physically active. It's good for you outdoors. You have a lot of freedom from social media, from your cell phone, from people. No one can contact you. It's probably one of the most liberating things you'll ever get to do in your life. And all the risks are manageable, and all something that we can reduce the risk of getting hurt while diving if we just follow some of the basic rules. And again, marine life are a risk, but if you know what not to pick up, not to touch, Steve Irwin died because he got too close to a stingray. He knew his risks and he got stingray, or the blue ring octopus, or, being careful around jellyfish or near sharks. Don't pick up a cone shell. I don't think the sea turtles are going to hurt you, although they look pretty mean. Knowing your gear. malfunctioning gear, panic underwater, things like that, getting tangled, things like that. So again, all stuff that can be mitigated and reduced. And then that's about it. All right. So I think just for time's sake, because I want to leave some time for questions. Again, we run a fellowship at Penn. There's my dive expedition. There we are in Turkey. We have a fellowship at Penn. We do a 1-year fellowship, 2 fellows a year. Any specialty can do the fellowship. You do not have to be emergency medicine based, even though I'm an emergency medicine physician. We've had anesthesia, we've had surgeons, we've had internal medicine, we've had family practice. I encourage you all to consider the fellowship if you want to. It's a great way to diversify your background. And it still is within the realm of wilderness medicine, because when you're out there on a boat scuba diving, that is the wilderness. It's kind of way out there, and it's far from home. Let me see. Anything else? Any other questions? I'll stop sharing. I know it's a lot. I know it was fast, and I apologize for that because it's a lot to cover, but it's what I do.
Thank you so much, Dr. Lambert, for your talk. And before we segue into questions, I want you guys to check out the chat. There was 2 links dropped. One is our swag giveaway, so feel free to fill out that. And then if you're interested in joining our board, there is the Google form for y'all to fill out to become a part of our board. Without further ado, we do have some questions in the chat. So our first question is, are you a member of the Explorers Club?
Yes, I am.
Let's see.
I
Feel
joined
free to
I joined the Explorers Club in 2000. I want to say 12. I applied in 11, got in 12. And just because you heard the kid in the background, life's been a little bit busy, so I haven't been to the annual dinner much lately. But yeah, I am a member of the Philadelphia chapter.
all right.
I have a question for you, Dr. Lambert,
Sure.
if I can interrupt you, Sam. Also, this is one of the only times I love learning about Boyle's Law and Henry's Law. So thank you for making physics fun for a little bit there. I'm curious about your scientific diving expeditions. When you're doing the things with nautical archaeology, are you doing mostly medical supervision, medical control things? Or are you there just as a scientific diver with no medical responsibilities at all?
No, I did my advanced open water, and so they made me a part of the team. I'm going to show you what the team looks like. So here we go. So there's the team, and these were PhD professors and PhD students. So this is Deb Pierce. She was the PI on this project. And a lot of these other people, some of these were Turkish postdocs and undergrads working for Institute for Nautical Archaeology, which is based out of Texas A&M. So I was advanced open water. And so they let me dive. Now, obviously, I'm not an archaeologist, so I was very, very basic in what I did. I took photos. I had a a metal detector. I was able to find a anchor column from a 2,000-year-old anchor, which was kind of cool. So that's kind of cool that I found something that was 2,000 years old. But it's a team, and they let me dive, and then I did the medical as well. And they had a chamber aboard. So I was there for the chamber as well. Where's the stop sharing? So stop sharing. Okay.
see. Our next question is, how often do you hear about USA Lear jets traveling to remote locations to transport dive patients who are injured?
So when we used to do, my team used to work for the Divers Alert Network, which is out of Durham, North Carolina, and they have a very robust medical team, and we help evacuate patients from all over the world. We are not contracted with Dan anymore. So when I was doing my work with Dan, we were helping people get evacuated. We're not doing per se we're making the recommendations. So putting somebody on a pressurized aircraft obviously comes with its risks, right? Because you're putting somebody between cabin pressure of 6,000 to 8,000 feet. Ideally, whenever we're evacuating somebody from with an injured diver who is still in the acute phases of their dive injury, we want to try to keep them at as close to sea level as possible, whether it's a helicopter flying over the mountains to a hospital in the Rockies or in wherever they are in the world, or they're flying from a remote island off the coast of Mexico. We're always trying to request aircraft that are flying in a non-pressurized cabin. Doesn't always work. So sometimes we do have to just, they try to get them as close as they can to treatment and then put them on a jet. But there are a lot of patients. Again, the rate of injury is low. And whenever a diver goes somewhere, one of the first things we say is, hey, what's the closest facility? So you never should go diving unless you know there's a certified or at least legitimate chamber where you can go if you're injured. There's a lot of things that happen overseas that are unfortunate for divers. So you should be careful whenever you're diving overseas. You don't want to just go diving if you don't know, your environment if you were to get injured. In terms of Divers Alert Network, yeah, I recommend Dan. There's Dan and there's Dive Ashore. There's two companies which do dive insurance, so travel insurance type. They have different models, business models. I'm not really sure about them. I have Dan. I use it, and I think it's great. I think I wouldn't ever dive outside the country without having Divers Alert insurance. Now, within the country, maybe not as important for someone like me because I know what to do. I'm a doctor, and most of the people in this audience are probably medically sophisticated enough to work their way around the healthcare system. But for friends and family who aren't in the healthcare system, highly recommend having travel insurance for sure.
Hi, good afternoon. Thank you for the talk today. I had a few questions about the pre-dive cardiology assessment. You talked a little bit about a PFO. What about divers that have unknown or pre-existing heart conditions that need to be evaluated before a dive? And what are some of the measurements that you're most concerned about, or congenital heart malformations that you're concerned about with that?
So at the end of the day, it's I think of it like a stress test, right? So scuba diving, physiologically, there's a couple things you have to worry about. So if somebody has a cardiomyopathy, you may want to evaluate them both from a cardiovascular standpoint in terms of a stress test, an exercise stress test, to make sure they can handle at least 8 METs. It used to be, we used to have a higher threshold. That was our threshold for metabolic equivalence that they could handle. But they've reduced it. Divers Alert Network did some research and they reduced it for recreational divers down to 7 or 8 METs. So I think a stress test would be important for anybody with comorbidities. I prefer echo because I want to make sure they don't have an underlying cardiomyopathy if there's a risk. In terms of congenital, I'm lucky. We're right here next to CHOP. So I have some really good pediatric cardiologists that I can refer to and just say, hey, how would you feel this person doing some sort of exertional exercise? And if they say, I feel comfortable, I think they're equivalent to 7 or 8 METs, I would probably let them dive. A lot of what we're doing with diving and dive physicals and dive education is shared decision making. Now, there are some other things that go into the cardiovascular, and it's cardiovascular, right? We could talk for hours about cardiovascular. So, for example, emergent pulmonary edema is a big risk. So people with undiagnosed or certain cardiomyopathies, they seem to be at greater risk for emergent pulmonary edema. But then there's people who don't have it and also at risk for emergent pulmonary edema. So another thing to ask somebody is, have you ever been in the water before? Have you ever had problems? Have you ever felt like you couldn't breathe when you get in the water? Because when you get into the water column, physiologically, a lot of things happen at the cardiovascular level to our bodies. And I know this only because it happened to me once when I got in very cold water without a wetsuit and my lungs filled up with fluid. So it does happen. That was during a triathlon and it was scary. But I learned like, hey, I should not be getting into the water cold. And so, and again, it changes with age. But that's a great question because cardiovascularly, that's probably one of our biggest hangups is how do we approve a diver? And so we work really closely with our cardiologist about those patients. But at the end of the day, it comes down to, does the cardiologist, do you think would you let this person exercise at X level? And if they say, yes, I feel comfortable, and the person's been in the water column before and they understand the risks, then we'll let them dive. our goal at Penn, what I teach the resident, the fellows, and the other attendees, our goal is to do everything we can to get you in the water safely. We are not like some people are like always say no. We are always say yes until we think it's okay. It's no longer safe. We really want people to dive because we think it's a fun hobby.
Thank you.
We
Alice
have
had a
another.
question.
Oh, sorry, go for it, Kimberly.
Sorry, I didn't mean to steamroll you there. One thing I really don't understand, and you mentioned it briefly in your talk, is why there's not more GI upset or GI side effects from diving. Just because that's a huge area of your body where you have gas and unequalized pressure.
Yeah, I mean, not to be gross, but if you have a lot of air in your colon, we have the benefit of having a lot of flexibility in our intestines, right? We can tolerate a lot of expansion. It'd probably be more uncomfortable than anything, and you're going to feel like you're going to have to pass gas or belch. From a surgical standpoint, people with pouches and stuff, they can dive. They do dive because they can vent, right? So we have the ability to vent from the GI perspective, but I would caution somebody if they have a GI illness and they're very gassy. I would caution you from diving because you accumulate a lot of gas at depth, and then when you come up, it's going to be pretty embarrassing for you. But generally speaking, it's not as we just don't see it as much. However, I mean, like I said before, a lot of self-treated patients, a lot of divers don't even know, they just deal with it, right? So there's a lot of patients who are divers who may not even think, oh, this is probably related to my diving, I should go to the doctor. And they might just have aches and pains for a few days. And it was probably a decompression related illness. And they just waited for it to get better on their own.
Thanks.
So we have a couple of questions in the chat. The one is, which region or state has the most amount of serious dive injuries in the US?
Well, I have to be careful because we just Divers Alert Network just came out with their annual report. So I haven't dissected through their annual report. So I think it goes without saying, for the United States of America, it's going to be Florida. I'm almost certain it's going to be Florida, just simply because of the Florida Keys and the amount of diving that's going on down there. One of our former fellows, we have a former fellow that's in Key West and a former fellow that's in Miami, and they're both busy seeing patients. It's going to be that or California, just because that's where the water is and that's where that's where recreational is. California water is colder, so I would imagine it's going to be Florida.
And then another question is, are there specific medical guidelines for, I'm going to assume this is diverse fitness or divers fitness?
Yeah, so the problem is for commercial divers, yes. So we have very specific guidelines from the Association of Commercial Divers, right? ADCI, and in Europe it's called IMCA, the International Marine Divers. I forget what the last one letters for, but IMCA and ADCI are two standards. It's Canadian, also the Canadian divers, commercial divers, has also a certification guidelines. So that's for commercial divers. So we do have some guidelines that can help us with commercial divers. But when it comes to recreational divers, no, we have, basically that's what the fellowship's for. We learn what are the risks and accepted comorbidities that you can dive with. There are certain things that whether it's Fred Beauvais' book or Steve Thom's book or Simon Mitchell's book, we have a couple textbooks and experts. It's going to be more consensus. The Undersea Hyperbaric Medical Society, that's my medical society, we have some consensus statement papers like on diving and asthma, diving diabetes. That's kind of where we are. We have to take it case by case, but there are guidelines. Yes.
And then to follow that up, I have two questions for you. So I'm a PADI instructor out here in California with really cold water. What would be one thing that you would, if you could, advise cold water California divers to look out for, be mindful for, just to keep themselves and their students safe?
I mean, for me, it's going to be, don't jump into a cold water. Get your wetsuit on, whenever I'm out in California now, I get the wetsuit on and I get water in the wetsuit and I get that nice warm layer between me and the body of water I'm going to be in, and I'm very covered. I have a hoodie, I have booties, I have a good gear. So I don't like cold water. So I would say just take care, be precautionary when it comes to the cold water. It's beautiful though. It's so much fun. California, the kelp beds are amazing. So if you've never dove the kelp beds, I highly recommend it as a lifetime experience. So kudos to you.
And yeah, it's a bit chilly out here now. And then my second question is, so I'm not as high up in the medical area as most of these people here. I'm an EMT and a diver for our local search and rescue team. What would be something that you would keep in mind as the medical person for a search and rescue team just to keep your people safe?
I think when we take care of rescue divers who come in for their dive physicals, the thing that I focus the most on is their mental health and well-being, because these are people who potentially are coming face to face with dead people, and there's nothing to compare you for being 2 inches from a dead person, and that's all you can see because it's dark black water, it's filled with silt. So I think mentally it's talking to their supervisor, making sure they're in the right, frame of mind and the right space to be able to do those types of activities, and having a low threshold to say, hey, now's the time to take a pause, as well as the aging diver, right? So the rescue divers who I think of like the EMT or or a police officer or whatever who comes to you and they haven't been exercising and keeping fit. You got to pay attention to your fitness, because of all the people, they're the ones that are going to be most likely thrown into a very acute situation, whether it's in the ice up in Maine or it's going to be contaminated water. So I think that mental health and the physical health are going to be the two things I focus on the most, and their training, making sure they're up with their certifications.
Thank you so much. Does anyone have any last questions?
I think we'll take that silence as a no, and we're also a few minutes past the hour, so I think this is a great time to close the talk. So, Dr. Lambert, thank you again so much. I always love these diving talks, and this one was really, really interesting. I've never heard about these scientific dives before from someone who actually does it. So, fantastic talk. Thank you so much.
Thanks, everyone. You guys are doing great. It's a great group.
Great. All right, folks. We hope to see most of you back in 2 weeks, again, where you have a talk on climate medicine, and as well, definitely make sure to check out our website and YouTube channel for free stuff, e-board applications, and more things like that. So thank you and have a good night.